Ok, bueno, yo creo que ya podemos empezar. Nada, pues muchas gracias a todos y todas por estar aquí en la noche de hoy. Este va a ser pues, nuestro último Topics in Neurosurgery del año, ¿verdad? Porque ya el mes que viene va a ser Navidad y yo creo que aquí, por más que nos guste la neurocirugía, nos gusta más la familia. Así que, ¿verdad? Vamos a tomar este como el último. Potencialmente no es nuestra última actividad, tal vez tenemos otra más, ¿verdad? Que depende del scheduling. Pero lo que va a ser, pues, lo que es esta serie de charlas va a ser la última del año, ¿no? Y yo creo que es una excelentísima manera de cerrar. Yo creo que es bien simbólica, ¿verdad? Porque el día de hoy tenemos la oportunidad de tener a nuestra colega Karolina Pellot, estudiante de tercer año del Ponce Health Sciences University, Escuela de Medicina, y que nos viene pues, a hablar un poquito de tratamientos quirúrgicos para fracturas de compresión vertebrales, ¿no? Relacionadas a osteoporosis. Y nada, digo que es simbólico porque pues parte de la idea de hacer esto, pues la primera pues se dio en febrero, esta charla, la última la estamos dando aquí en diciembre durante el año, y la idea era que eventualmente lograr esto mismo, poder conectar con otras escuelas de medicina. Yo creo que romper esta barrera un poco invisible que a veces uno cree que existen y realmente no deberían existir, y más ahora que tenemos este contexto nuevo donde tenemos que trabajar juntos para ver si queremos lograr esa meta común de mantener la neurocirugía aquí en Puerto Rico, aun si todavía no hay un programa académico vigente. Bueno, lo hay todavía, ¿verdad? Pero a largo plazo. Y esperemos que se resuelva rápido, pero es lo que crear estas relaciones. Así que agradecemos un montón a Karina por estar aquí en el día de hoy. También agradecemos un montón al doctor Ortiz, como siempre, por sacar un ratito de su tiempo para estar con nosotros y nosotras. Así que nada, Carolina, el piso es tuyo. Gracias de nuevo por estar aquí.
Gracias a ustedes por dar esta oportunidad, de verdad es súper buena. Y pues nada, obviamente la voy a dar en inglés, pero el tema lo trajo la verdad uno de los de nuestro grupo, y pensé que era súper interesante por los procedimientos que traía, pero nada, voy a comenzar. Si tienen alguna duda o pregunta, raise your hand o la pueden decir al final, pero muchas gracias. Así que pues nada, voy a empezar. So the topic for today is surgical treatments for osteoporotic vertebral compression fractures. I like to start off kind of everything with a little bit of anatomy to kind of situate ourselves on where we are and what we're talking about. I know that we all took anatomy, unless there's somebody from first year that is currently taking it. So essentially, so the spinal column, we know that it's one of the most important parts of the body, really, because it has many different functions, and it enables us to move, to have balance, and to have our posture, and it also protects the spinal cord, right? So the spine is composed of 33 bones called the vertebrae, and it is divided into 5 sections. You have the cervical, the thoracic, lumbar spine sections, the sacrum, and the coccyx bones, and essentially labeled in the parts from 1 to 10, I believe, would be 1 spinal cord, 2, you have the nerve roots, 3 vertebral body, 4 lamina, 5 vertebral canal, 6 you have the pedicles, 7 the disc, 8 articular facet. The number 9 is the spinous process, and number 10 is the transverse process. So kind of to get a little bit into the topic, so osteoporosis, obviously osteoporotic fractures. Osteoporosis, like the word says, it's osteo, which is bone, and porosis, which is porous. That's what I love sometimes about words. They make sense. So essentially, osteoporosis is it's a disease that causes bones to become really weak and kind of brittle. So sometimes they become so brittle that what you would consider normal activities per se, or not so much traumatic injuries, could actually cause a fracture. They commonly occur in the hip, wrist, or spine. So because bone is living tissue, it is constantly being broken down and replaced, the osteoclast, the osteoblast. So osteoporosis also occurs when the creation of new bone kind of can't keep up with the breaking down of the bone. It can affect men and women, but usually it is more common in white Asian women, especially if you are post-menopause. And essentially, because your bones are in a state of constant renewal, new bone is being made, broken down. So when you're young, the process of making bones is obviously a little bit faster, and breaking down is a little bit slower. So also, as you age, this also becomes a higher risk factor for osteoporosis. So the risk factors, like I mentioned, it's essentially sex, age, race, family history, hormones, diet, medical conditions, and even lifestyle choices. Now, as an introduction towards the osteoporotic fractures, so osteoporotic fractures are those that essentially occur from maybe a fall or a standing height, or essentially not major trauma, like, for example, a motor vehicle accident. And vertebral compression fractures are the most common type of osteoporotic fractures. They often occur like in the mid-thoracic spine or the thoracolumbar junction, and the fractures can result in pain, essentially, or limited functioning for the patient. And one of the highest risk factors for having an osteoporotic fracture is the previous osteoporotic fracture. So that's why you got to follow up these patients, not just for the fracture, but also how they're treating their osteoporosis. So these are essentially just like kind of the process that happens. You know, you have the bony block or the vertebral body that kind of collapses. That's why it's a compression fracture, and the symptoms can cause severe pain, deformity, and even loss of height. So vertebral compression fractures, like I had mentioned, is one of the most common fractures for patients with osteoporosis, and it affects about 750,000 people in the US, and an estimated 25% of all postmenopausal women in the US. The occurrence of this condition really steadily increases as people age, obviously, with an estimated of about 40% of women age 80 and older being affected. So like I had mentioned, you know, more commonly in elderly women, usually due to osteoporosis, but it can also be common in young men, but from trauma. The locations, half of it occurs in the cervical spine, and the other half is divided between the thoracic, lumbar, and sacral spine. So the etiology, primarily trauma, but also you have the pathological fractures, which osteoporosis comes into here, the pathologic fractures, but you could also have these type of fractures due to malignancy like bone metastases or infections like Pott's disease. Oops. Okay, 3. So the clinical manifestations essentially are, if it's an acute compression fracture, well, obviously you're going to have an acute onset of back pain. You can have back pain that is due to postural changes. The back pain can actually decrease if you're lying on your back, because obviously you don't have too many changes and you're resting. There's also tenderness to palpation in the affected area, and you can have decreased spinal mobility because of the pain, obviously. The complications that it can also cause, besides back pain, which is the most common one, thoracic kyphosis, lumbar lordosis. They could also have decreased pulmonary function if you have the curvature of the spine, kind of, you know, the thoracic kyphosis and lumbar lordosis can also lead to that. Disuse osteoporosis and deep venous thrombosis due to the inactivity. Also, you can have spinal cord injuries if you have a vertebral fracture. So if you have severe injury to the spinal cord, you can have spinal contusions that can lead to neurological deficits. And you can also have hematomas, you know, if you injure the vertebral artery. Okay, so this picture I just kind of wanted to show you guys. So this is a CT angiography of the cervical spine with contrast, and you can see that there's a burst fracture in C2 with pedicle involvement. And I just thought I was curious because you can see there's an absence of the contrast on the left vertebral artery above C5, and this is one of the complications that you could have because it wasn't just a fracture, but it also injured the vertebral artery. So the testing and diagnosis for this, patients with suspected acute vertebral body compression fracture should be evaluated with plain radiographs to confirm the diagnosis. Osteoporosis per se can lead to various types of vertebral abnormalities per se. It can include wedge fractures and also biconcave fractures, just by aside from the compression fractures. And the severity is also graded radiographically. So you can have grade 1, that's 20 to 25% height deformity. You have grade 2, which is 25 to 40% height deformity. Grade 3, which is more than 40% height deformity. So while the diagnosis can usually be made through history and physical examination, you can use CTs, X-rays, MRI, or the DEXA scan to kind of evaluate and see radiographically where it is located, how much compression there is, in order to kind of get a full picture. So additional evaluations that are usually done, you do a neurological exam. For neurological findings, obviously, if they have any deficits, focal weakness, any sort of upper motor neuron signs, any other type of neurologic abnormalities that could have been caused by the retropulsed bone fragments. That usually happens if the compression is severe. And you also do laboratory findings or laboratory evaluations to kind of indicate or diagnose if there is a secondary cause of the osteoporosis, such as renal or liver disease, or maybe hyperthyroidism, Cushing syndrome, etc. So this is another picture where you can see in the one on the left, this is an X-ray of the lumbar spine. So this is a chronic compression deformity of the L4 vertebral body with displacement towards the spinal canal beyond the posterior vertebral lines of L3. So you can kind of see like that kind of shape that goes off. And it also has an exuberant anterior osteophyte. Then the one on the right is essentially a burst fracture of T12. So this is a CT, and there's a burst fracture in T12 with retropulsion of the fragments. Here's another picture that I thought was also kind of very curious, because you see another view of it, where you can also see a burst fracture of the T12 vertebral body. So the compression fracture kind of the superior end plate, and you can see the other view, the fracture of the vertebral body. And then this next picture, which is also a view of both acute and chronic vertebral fractures. So this is an MRI of the lumbar spine, and you can see the compression deformities of T8, you have T8, T10, and L4 vertebrae. So the treatment for this, obviously the first step for treatment for these fractures isn't surgery. So most of the things that we study, the first step isn't always surgery. Most of the time you're going to try something else. So the initial management for these osteoporotic vertebral compression fractures should actually include pain control. Obviously the patient is in pain, and also activity modification. So you can use oral analgesics, which are first line therapy to relieve the acute pain. Sometimes they can do bracing, although it's not typically done. Obviously exercise, treating the actual cause of osteoporosis, and lifestyle factors are really, really important to modify, because if the patient, their lifestyle is sedentary, they don't have really good eating habits, they smoke, they drink a lot of alcohol, those are modifications that are usually made before we take into consideration surgery. The drug management essentially are oral analgesics like acetaminophen, ibuprofen, naproxen. You can also use a combination of mild opioids with acetaminophen. You can use mixed mechanism drugs or centrally acting analgesics also. Now, for the part that we're all waiting for, the actual surgery. So these procedures, the most common ones that are done are vertebroplasty and kyphoplasty. So while vertebroplasty and kyphoplasty appear to be performed, they're performed very similarly. Kyphoplasty is actually performed more frequently than vertebroplasty. And kind of in the picture, you can see what the procedure looks like, but we'll dive in a little bit into each one. So vertebroplasty, essentially percutaneous vertebroplasty, is a minimally invasive procedure that's used to treat these spinal compression fractures. So the goal of this surgery is to reduce the pain while also being able to stabilize and strengthening the vertebra that was actually fractured. So in the procedure, kind of how it goes, the patient lies down on the operating table. The surgeon punctures the skin over the affected vertebrae with a biopsy needle, and using X-ray guidance, the needle is inserted into the vertebrae through the pedicle or sometimes slightly above it. And using either a rotary motion or also a tapping mallet, the surgeon pushes the needle into the bone at an angle until it reaches like deep into the body of the vertebrae. Now there's a cement that's low viscosity, and it's injected into the vertebrae, which then spreads kind of throughout the weakened portions of the bone. And depending on how rapidly it spreads, a second injection can actually be necessary. Then the cement dries pretty quickly, which creates kind of like a cast internally inside of the fracture. And then the patient can just turn over, they let it harden, which usually takes about 5 minutes. And then it can be repeated depending on how the surgeon finds the results. So this is essentially what it looks like, kind of a little picture of what it looks like, right? This is a transpedicular placement of the trocar. The cement is called polymethyl methacrylate, usually the one that they use in case anybody was curious. I just wanted to know. And this is what it looks like. So you can see on the picture on the left, this is a lateral radiograph of the fractured vertebrae, which shows the initial placement of the trocar. And then the picture on the right, you have the actual injection of the cement in the vertebral body. So the complications, obviously, there's no surgery without possibility of complications. So even though it's well tolerated, this procedure, the complications are usually minor. They occur at a rate at maybe 1 to 3%, but there are risks. Obviously, there's hemorrhaging, blood loss, fractured ribs or nearby bones. You can have fever, nerve root irritation, infection, and sometimes the cement can actually flow outside of the vertebral body. So vertebroplasty, kind of like a little bit of review, kind of comparing it towards kyphoplasty. The cement is injected under high pressure. There's no potential to correct the vertebral deformity. There's no bone tamp involved, and there's also greater potential for extravasation of the cement. Now we go into kyphoplasty, which is the other procedure that's kind of similar, but the difference here is that the trocar, there's a trocar with an inflatable balloon, and it is inserted into the vertebral body. The balloon is actually inflated so it can re-expand the vertebral body. And then in that hollow space that's created, it's where you would fill it up with the cement. So this is kind of what it looks like, right? So on the left, you can see where the surgeon has placed the needle in the fractured vertebrae. Then in the middle one, you can see the balloon tamp that is then inserted, inflated inside the bone. And then to the far right in the picture, you can see the empty cavity that was filled with cement to kind of strengthen the vertebrae. Here's another picture, which is kind of the two pictures of the before and after of what it would look like. And then finally, the complications, obviously. So here the complications are pretty much similar. So you have infection, bleeding. Sometimes some patients can have increased back pain. You can have tingling and numbness if there's nerve damage, allergic reactions, and again, possible leakage of the cement from the vertebral body. So this is a review of what that would entail. So kyphoplasty, essentially, cement is injected under lower pressure because you have the balloon expanding and creating a space, so the cement doesn't have to go against so much pressure inside of the vertebral body. You do have greater potential to reverse the vertebral deformity because you kind of expand it with the balloon. The bone tamp is used to increase the space for the cement, and there's limited potential risk of extravasation of the cement. So which one's better, really, if they're pretty similar? So they're relatively new techniques, essentially, for the treatment of pain. So kyphoplasty differs, obviously, from vertebroplasty because of that balloon that's first inflated in the vertebral body to create that cavity into which the cement is injected into. So theoretically, inflating the balloon can increase the vertebral height and reduce kyphotic deformities, while injecting the cement under the lower pressure that I had mentioned and minimizing the cement extravasation. There wasn't really, or there hasn't been a randomized trial directly comparing the two procedures. So therefore the available data was only in an indirect comparison. So on the basis of a systematic review that was done with literature, it was found that patients undergoing either procedure really achieve comparable reduction in pain, which is the most important part. Biomechanical studies suggest that kyphoplasty may initially be more efficient or effective in improving the vertebral height, but that its effect subsequently is lost through repetitive loading. So these findings were consistent with like clinical studies that were done, which found really little difference between the procedures for improvement of vertebral height or kyphotic deformity. But overall, the complication rate is low for both of them. However, for vertebroplasty, it appeared that they had a higher rate of cement extravasation, which is one of the risk factors that I had mentioned, with also associated pulmonary emboli and compression of neural elements. So as the indications of vertebroplasty and kyphoplasty continue to actually expand, some trials are trying to compare the two procedures more directly to actually have conclusive effects on the relative strengths and weaknesses of the different clinical scenarios between them. So these are essentially just the criteria that can be used to consider the candidates for these surgeries. So patients with criteria such as osteoporotic vertebral compression fractures that have been present for more than 2 weeks, painful metastases, multiple myeloma, painful vertebral hemangiomas, or vertebral osteonecrosis. And then if we compare it to the criteria that you should not undergo, patients that should not undergo these procedures are people that have vertebral compression fractures that are completely healed. So sometimes you can find vertebral compression fractures in patients incidentally. And really, if they're completely healed and not causing pain, you shouldn't risk doing surgery on these patients to actually potentially expose them to all the risk of the surgery. If you have spinal curvature that is due to other causes than osteoporosis, spinal stenosis, or herniated discs that are not associated with vertebral compression fractures, if you have an untreated coagulopathy, obviously you can't endure these surgeries, you might bleed, osteomyelitis, or discitis. So another procedure that I found that was kind of done for these types of injuries is spinal fusion surgery, which is sometimes used for spinal compression fractures to eliminate the motion between the two vertebrae and kind of relieve the pain. The procedure essentially just connects 2 or more vertebrae together and holds them in the correct position to keep them from moving until they have a chance to grow and fuse together. But really, this is not commonly done, what I've found, or it's used as a last resort, and really the other 2 procedures are more commonly done for these types of fractures. So this is just a picture that you can see an anterior posterior x-ray of the cervical spine, and you can see the spinal fusion that was done. So the complications, obviously, again, every surgery has complications. You can have infection, you can have bleeding, you can actually have recurring symptoms. You can have pseudoarthrosis, nerve damage, and even blood clots. They are uncommon, but like every surgery, you have your complications that can happen. So as a form of conclusion, kind of just to review, so vertebral compression fractures, especially due to osteoporosis, are primarily going to be treated with conservative management. Surgery is not going to be the first option that they're going to pick. So usually you would do pain medication or physical therapy, sometimes bracing can help. And then if you do have surgical treatments, you can have the spinal fusion, which is when you have kind of like the last resort kind of scenario. And the more common ones used that I had mentioned, which are vertebroplasty and kyphoplasty. So these are my references in case anybody wants to read all of them. You're welcome to. And if you have, any questions, any concerns, you can ask them right now. So thank you for your attention. Let me see. I can see questions in the chat. Let me check. The effects of the cement leaking, that's actually a good question. I'm not sure of what the effects of the cement leakage are. Usually what I found was that if it does leak, what it does is it affects the structures around it. So it could affect nerves, it could affect even vasculature, and it's kind of an impingement per se. So those were the only effects that I saw, but I couldn't be very specific about it. But if it does leak, essentially, yes, it just could affect the structures around it, especially the nerves.
Muchas gracias por esa presentación, Karolina, fue excelentísima. Aquí también Javier compartió un buen recurso pues, para lo que estaba mencionando Karolina de las vertebroplastías y las quifoplastías. Nada, si alguien más tiene alguna otra pregunta o duda, como saben, ella dio su presentación en inglés, pero si quieren hacer la pregunta en inglés o en español o por el mismo chat, siéntanse
Sí,
en favor.
claro. Hablo español e inglés, más nada, sorry.
No, no, tanto, no nos pongamos claros.
Pero sí, nada. Tienen preguntas, dudas, agobiaciones, estamos aquí.
Muy buen trabajo, Carolina. Muy buena presentación. Para que tengan una idea, esto es bastante común, ¿verdad? Como que yo durante una noche de guardia me pueden llegar como 4 consultas de estas. Y para que tengan una idea de cómo esto va a presentar, no es como, it's not how you would think. Muchas de estas cosas son findings bien incidentales, ¿verdad? Muchas veces tienen un viejito, una viejita, because that's usually how it goes, ¿verdad? Estos son gente mayores de edad. Y se cayeron, se están quejando de un poquito de dolor de espalda, le hacen un CT scan de toda la espina, de la cabeza, whatever, y encuentran que tiene un compression fracture, ¿verdad? Y en ese momento, pues, tú te dejas llevar por todo lo que te han mencionado sobre si tiene dolor, si tiene algún déficit neurológico, ¿verdad? Lo de los TLEX scores. No sé si ustedes alguna vez han leído de los TLEX, que es como un scoring system que nosotros usamos a ver si algo es operativo o no. Pero usualmente todos estos viejitos lo que tienen es ese compression fracture, que a veces es como que, it's not a big deal, no es como que se ve súper explotado en el CT. Y lo que nosotros usualmente hacemos es como que we get upright x-rays, como que le tiramos un film mientras están de pie para ver cómo de inestable o deforme se pone ese disco una vez le pones peso. La realidad es que muchas personas tienen fractures que ya son subacute o crónicos. Como que tú lo ves y esta persona tiene ese fracture hace tiempo. A veces tienen mucho, porque es que son viejitos y tienen la espina con osteoporosis, con todas estas cosas, and they have a lot of those. Y la realidad es que muchas veces we just don't do anything about it. Como que pues, you have that broken there y pain management. Si él tiene muchísimo dolor o algo así, o está súper comprimida, pues entonces we can go down the path of Kyphoplasty y todas esas cosas. Si está completamente destruido y tiene un impingement de un nerve, pues hay tal vez de comprimir y poner instrumentación, pero en realidad es como que like everything else in neurosurgery, la evidencia sobre eso, el Kyphoplasty y todo eso, ¿no? Es como que es super concrete. Pero muy buen trabajo, Carolina.
Gracias, means a lot. De verdad.
Sí, esa era realmente mi pregunta, va más o menos por ahí. Nada, realmente qué es lo que se ve, porque obviamente si le pones, por ejemplo, el cemento a estos pacientes, pues tú estás deteniendo algo, pero no es que lo estás resolviendo. Y más que todo, si no decides intervenir en estos pacientes, hay veces que es crónico, subcrónico, pero subacudo, discúlpame, pero se sabe o por lo menos se tiene una idea de cuáles son esos factores de riesgo que pueden llevar a que esta persona se lesione más aún, aunque ha llegado a este punto. Normal,
usualmente, ¿verdad? Es como que pues son viejitos, tienen osteoporosis, tienen tal vez renal disease. Los pacientes en la vida real tienen un myriad of things, como que the compression fracture is the least of their worries. Pero a ti te van a consultar por el compression fracture nada más. Y tienen tantas otras comorbilidades que lo hacen prone a que se sigan rompiendo la espalda. Para que tengas una idea, no necesariamente ni tienes que tener todas estas cosas que acabo de mencionar. Just think about it desde una perspectiva neurológica puramente. Una persona que tiene demencia, Parkinson, anything like that, está más predispuesto a caerse, ¿verdad? Cosas que tengan en la casa, que se tropiecen, están más predispuestos a caerse. All of those things increase the risk factors de que estas personas pueden seguir teniendo breakage in their bones, ignorando todo lo demás, ¿verdad? Y again, this is not a 15-year-old that comes with a compression fracture like this, ¿verdad? It's usually an old person. Gente que tiene cáncer, que le han dado radiación en la espalda. You would be surprised como que how many really freaky fractures I see de gente que ha tenido radiación en la espalda por cáncer. Like, it can get pretty debilitating the weak, esa espalda a veces. The other thing, perdí el train of thought. Anyway, iba a decir algo y se me olvidó qué era.
Ya te acordarás. Nada, gracias por eso acá. ¿Alguien más? ¿Alguna otra duda o pregunta que puedan tener? ¿O algún comentario que quieran hacerle? Algo que hayan visto les parece interesante o otra cosa que hayan querido leer. Aquí Javier nos comparte algo en el chat hablando sobre...
Ahora me acordé. Muchas gracias, Javi, que lo compartiste. Una de las razones que nosotros hacemos esto es por dolor, ¿verdad? Y la realidad es que ¿cuál es la razón más común de dolor de espalda? Cosas musculoesqueletales, ¿verdad? Que no necesariamente son ni cosas estructuralmente wrong with a person. Muchas de estas personas a veces tienen dolor de espalda, en baseline, se cayeron, ¿verdad? Pues obviamente tuvieron el burst fracture, whatever, que tal vez es un acute worsening of the pain, pero no tan solo eso, ahora están como que trincándose, porque como les duele la espalda, se trincan, como se trincan, la espalda se pone con más spasms y todo eso, les da más dolor de espalda, y como están caminando weird por el dolor, entonces esas otras áreas que ya tenían como que con dolor, se le empeora el dolor, le hiciste el Kyphoplasty, lo que sea, y de repente, el dolor no se me fue. ¿Por qué? Porque you have a worsening of your already chronic back pain por otras causas que ya son beyond that structural thing. ¿Entiendes?
Okay, es una mezcla de cosas. Definitivamente yo creo que crear un algoritmo para separar cosas es lo más útil aquí, pero aún así ni eso, ¿verdad? Eso sobre simplificar muchas veces.
I mean, es como todo en la medicina, we just treat things and hope for the best, y pues hay gente que el Kyphoplasty le funciona y pues hay gente que no. You just keep going down whatever path you need to go para ayudar a la gente.
Claro. Nada, si nadie más tiene, ¿verdad?, dudas o preguntas o comentarios adicionales, pues nada, quiero terminar agradeciéndole de nuevo a Karolina por su tiempo en la noche de hoy, de verdad. Espero que a ella le haya gustado esta experiencia, como estoy seguro que me encantó a mí, ¿no? Y como estoy seguro que también le gustó a todos ustedes. Nada, el próximo año pues vamos a comenzar con esta iniciativa nuevamente. Saben que si alguien está interesado o interesada, ¿verdad?, nos pueden escribir a nuestro grupo, que es el de AANS RCM Student. Lo voy a poner aquí. Nos pueden buscar en Instagram, ¿verdad? Y también van a encontrar el link para nuestro canal de YouTube, el cual pronto, tan pronto como mañana, pues estaré subiendo los videos de esta grabación, ¿no? Y también la grabación del Dr. Ortiz, que nos dio la semana pasada una excelente charla sobre su programa en la Universidad de Indiana. Así que si conocen a alguien que esté interesado por esto y que no pudo venir, pues se lo comparten. Bueno, muy buenas noches a todos y todas. Gracias por venir.
Gracias, que tengan buenas noches todos.